Foundations of Maternal Newborn and Women's Health Nursing by Murray McKinney, Holub, and Jones. 7th edition, Chapter 27, Women's Health. Preventative Healthcare. There is an increasing demand for women's healthcare providers as more is learned about health risks specific to women and their need for preventative care. Certified Nurse Midwives, CNMs, and Women's Health Nurse Practitioners, WHNPs, often provide basic preventative health care to non-pregnant women. This chapter focuses on examinations and screening procedures recommended to maintain the health of women. It also will include information as it relates to immunizations, benign and malignant disorders of the breast, cardiovascular disease, menstrual cycle disorders, premenstrual syndrome, PMS, medical termination of pregnancy, menopause, osteoporosis, pelvic floor dysfunction, common benign and malignant disorders of the reproductive tract, and infectious disorders of the reproductive tract. National emphasis on women's health. 2 national programs have had a major impact on women's health. The Women's Health Initiative, WHI, of the National Institutes of Health, NIH, was a major 15-year research program to address the most common causes of death, disability, and poor quality of life in postmenopausal women: cardiovascular disease, cancer, and osteoporosis. Healthy People 2020 continues to have a health promotion and disease prevention agenda coordinated by the U.S. Department of Health and Human Services. Healthy People 2020 goals. So I'm just going to hit the high points of this without saying all the numbers because it should have been a table. Okay, increase the proportion of adults 20 years and older who are at a healthy weight. Lower breast cancer deaths. Reduce deaths from cancer of the cervix. Increase cervical cancer screening. Increase the proportion of adults who receive a colorectal screening. Increase the proportion of cancer survivors who are living 5 years or longer after diagnosis. Reduce hip fracture hospitalizations among women 65 years and older. Reduce the incidence of gonorrhea in women between the ages of 15 and 44. Reduce the prevalence of chlamydia trachomatis infections among women 15 to 24 years old who attend a family planning clinic in the past 12 months. Reduce congenital syphilis. Reduce coronary heart disease deaths. Reduce stroke deaths. Health maintenance. Health maintenance refers to measures that can be taken from prevention or early detection of specific diseases. Unfortunately, many women do not take advantage of the recommended health maintenance procedures and choose to seek care only once a problem exists. For others, the only health care they receive comes from a gynecologist or nurse practitioner, often with their annual checkup. Therefore, it is important that those who provide health care for women are familiar with principles of screening and counseling in areas that are not traditionally associated with gynecology, such as assessing risk factors for colon cancer and heart disease. Health history. The health history identifies risk factors for a variety of conditions and may be obtained from sources such as questionnaires, interviews, and records. The focus of a health history depends on the woman's age, but some topics should be discussed with all women. Box 27.1 provides a summary of the information to obtain. These topics include dietary intake, physical activity, habits, and sexual practices. Discussions of drugs should include long-term use of prescription and over-the-counter medications. Illicit drugs also should be discussed to provide the safest care for the woman. Questions about use of complementary and/or alternative medicine should be included in the woman's history. A woman's health history often identifies actions she takes to promote her health. Many people take herbal or other botanical preparations, but do not mention them because they do not consider them drugs. The nurse should specifically ask about use of these preparations or any therapies the woman may use in addition to medically prescribed interventions to obtain the most complete information for the medical history. Family history identifies many risk factors that cannot be modified. History of diabetes, hyperlipidemia, heart disease, osteoporosis, and thyroid disease suggests the best choice of screening tests. A list of family members who had cancer, the type of cancer they had, and their age when it was discovered provides important information about the woman's risk for cancer, particularly breast and colon cancer. A family history of heart disease is especially important when the woman is postmenopausal because the level of estrogen, which provides some protection against coronary artery disease, decreases after menopause and obesity may increase. If family history, obesity, or other factors increase a woman's risk for heart disease, a baseline electrocardiogram, stress test, and analysis of cholesterol and lipid profiles may identify other risk factors. A psychosocial assessment helps caregivers determine the best way to teach the woman health promotion behaviors. Inquiry can help identify her means of support and also possible risks to her well being, such as domestic, intimate partner violence. Physical assessment. A complete physical examination is essential to detect general health problems and to identify positive aspects of health. Refer to Physical Assessment textbook for a full explanation of the process of physical examination. Blood pressure, temperature, pulse, respirations, and weight are measured at each visit. Height is taken at the initial examination and yearly after that. Loss of height, abnormal curvature of the vertebral column, dorsal kyphosis or scoliosis, and a thickening waistline in the absence of weight gain are important observations in identifying osteomalacia, softening of bones, or osteoporosis, increased spaces, porosity of bone. The heart is auscultated to determine rate and rhythm and detect heart murmurs or irregularities. Auscultation of the lungs identifies abnormal sounds that may suggest the presence of fluid secondary to heart dysfunction or malignancy. The extremities are observed for varicosities or edema, and pedal pulses are palpated for strength and equality. Reduced sensation while palpating legs and feet may indicate circulation problems often associated with diabetes. The abdomen is palpated for tenderness, masses, or distension that may indicate the presence of benign or malignant tumors. Additional assessments are necessary if the woman is in a high-risk group. For instance, if she has a family history of diabetes mellitus, tests such as glucose tolerance test or hemoglobin A1C may be indicated. If she has a history of multiple sexual partners or a sexual partner with multiple contacts, testing for STDs, including HIV infection, is indicated. Preventative counseling. Physical examination provides an excellent opportunity to counsel women about preventative measures that often reduce their physical problems. Major preventable problems are overweight and obesity, inactivity, and smoking. Overweight and obesity are associated with numerous health problems such as diabetes, hypertension, stroke, and CAD, as well as some cancers of the breast and reproductive organs. Some of these obesity-related conditions are leading causes of preventable death. Non-Hispanic blacks have the highest age-adjusted rates of obesity, 48.1%, followed by Hispanics, 42.5%, non-Hispanic whites, 34.5%, and non-Hispanic Asians, 11.7%. Obesity is higher among middle-aged adults of 40 to 59 years, 40.2%, and older adults aged 60 and over, 37%, than among younger adults aged 20 to 39, 32.3%. Counseling about self-care measures to improve health should be offered. Positive health behaviors such as adequate physical activity or making the decision to stop smoking should be reinforced. Use of latex condoms should be emphasized for high-risk women and multiple sexual partners or those whose partners had multiple sexual partners. Counseling about diet may identify measures that improve multiple problems. For example, a weight reduction diet can include measures to improve calcium intake, to slow osteoporosis, to lower cholesterol, and to reduce diabetes severity. Achieving adequate exercise can reduce diabetes effects, lower weight, reduce cholesterol levels, and slow osteoporosis. A woman often feels better physically and emotionally as she achieves her personal goals, and the nurse can provide consistent encouragement. The history or physical examination may identify other areas for patient counseling. These include the dangers of malignant melanoma with repeated exposure to ultraviolet rays of the sun. In addition, counseling and referral for alcohol and other substance abuse may be needed for some women. Domestic violence may be discovered, requiring counseling for the woman to deal with this complex social problem. Immunizations. Determining the woman's need for immunization is becoming more common at her annual well woman checkup. Immunization needs will vary with the time of year, the patient's age, and history of infections. Fear of adverse effects from immunizations may become evident. Updated information about recommended immunizations is available from cdc.gov. Influenza vaccine is often offered during the fall and winter. It is not unusual to hear people say they had the flu shot last year and got the flu anyway, so teaching is important to encourage the vaccine. The composition of annual flu vaccines must be determined well before the infections start to emerge, so they may be more effective in one year than another year. People often do not realize that their annual vaccines require about 2 weeks to become effective, and that they will show signs of the infection if they have already acquired it at the time of their vaccination. Hepatitis B vaccine may be offered if the woman has not had it. Rubella vaccine may be given if the woman has never had the infection or vaccine and is not pregnant. Pregnancy testing is done and the rubella immunization is delayed until after birth if she is pregnant. Adults should receive a dose of tetanus and diphtheria every 10 years. One dose of tetanus, diphtheria, and acellular pertussis vaccine, Tdap, should be given to adults ages 19 through 64 as a substitute for one of their TD immunizations. Tdap is especially important for healthcare professionals and anyone having close contact with an infant younger than 12 months. Pregnant women should get a dose of Tdap during every pregnancy to protect a newborn from pertussis. Screening and self-examinations. The value of screening procedures is based on two assumptions. One, prevention is better than cure, and two, early diagnosis allows early treatment while the pathologic process is most curable. Some screening procedures are recommended for all women of reproductive age, including some screening procedures for early detection of breast cancer, as well as vulvar, self-examination, and screening for cervical cancer. Additional tests depend on the age, history, and risk assessment of the woman and might include the following. Testing for STDs such as gonorrhea, chlamydia, syphilis, and HIV. Testing for rubella immunity, which is particularly important in the childbearing years, although the overall incidence of the disease is very low in the United States. Tuberculosis skin testing or chest X-ray examination. Cholesterol and other lipid profile testing women at risk for CAD, particularly important after menopause. Fasting glucose testing or other tests to identify development of diabetes recommended every 3 years after age 45 or earlier if the woman has high risk factors such as family history or being overweight. Urinalysis to detect signs of UTI. Thyroid function tests, which may be indicated if the woman exhibits signs of thyroid dysfunction such as heart palpitations and heat intolerance. Serum testing for genes associated with specific cancers such as BRCA1, BRCA2, or P53 genes associated with breast and some other cancers. Serum testing for CA125, a tumor marker that may be elevated with ovarian cancer. Transvaginal ultrasonography, which may be recommended for women who are at increased risk for malignant disorders of the reproductive tract. Fecal occult blood test yearly. Bone density test every 2 years starting at age 65. An earlier start to bone density screening may be recommended for women at higher risk for osteoporosis. A colonoscopy every 10 years after age 50. A yearly colonoscopy may be recommended if the woman has a family history of colon cancer. Screening for breast cancer. Because of the lack of evidence that indicates a clear benefit of physical breast examinations done by either a health professional or self-examination performed by women, the American Cancer Society no longer recommends them. Still, all women should be familiar with how their breasts normally look and feel, report any changes to a healthcare provider right away. Most women have an average risk for breast cancer and should begin yearly mammograms at age 45. Women should be able to start the screening as early as age 40, desired and agreed upon by the healthcare providers regarding when to begin screening. At age 55, women should have mammograms every other year. The women who want to keep having yearly mammograms should be able to do so. Regular mammograms should continue for as long as a woman is in good health. These guidelines are for women at average risk for breast cancer. Women at high risk because of family history of breast condition or another reason need to begin screening earlier and or more often. Despite the known value of mammography, many women have never had a mammogram. Reasons for this include lack of healthcare professionals' recommendation, expense, fear that radiation exposure will cause cancer, fear of pain, and reluctance to hear bad news. Nurses provide information and reassurance whenever possible, and in this way, help the woman overcome her objections to the use of this valuable screening tool. Mammography is relatively expensive, but part of its cost is usually covered by health insurance, Medicaid, or Medicare. Screening mammograms may be offered by community agencies at low cost. Acknowledge that brief discomfort occurs when the breast is compressed between two plates while the image is obtained. Scheduling the mammography after a menstrual period when the breasts are less tender reduces discomfort. Knowing that mammography has minimal to non-existent risks because very low dose exposure to radiation is used, may help women overcome some of their fear. Vulvar self-examination. Vulvar self-examination should be performed monthly by all women older than 18, and by those younger than 18 who are sexually active. Vulvar self-examination is visual inspection and palpation of the female external genitalia to detect signs of precancerous conditions or infections. The woman should sit in a well-lighted area and use a hand mirror to see her external genitalia. She is taught to examine the vulva in a systematic manner, starting at the mons pubis and progressing to the clitoris, labia minora, labia majora, perineum, and anus. Palpation of the vulvular area should accompany visual inspection. She should report to her healthcare provider as soon as possible the presence of any new moles, warts, or growths of any kind, ulcers, sores, changes in skin color, or areas of inflammation or itching. Increasing rates of HPV are associated with increased incidence of vulvar intraepithelial neoplasia, VIN. Pelvic examination. The complete gynecologic assessment includes a pelvic examination. The woman should schedule the examination between menstrual periods and should not douche or have sexual intercourse for at least 48 hours before the examination. She also is advised not to use vaginal medications, sprays, or deodorants that might interfere with interpretation of specimens that are collected. The procedure is carefully explained before the examination, and the woman empties her bladder. Although pelvic examinations are relatively painless, most women dislike them and welcome sensitive, considerate support. Women who have undergone female genital mutilation need extra consideration. A pediatric vaginal speculum may be needed for these or other women with a very small vaginal opening. Routine preventative pelvic examinations may be impossible for women who have only a tiny opening left for drainage of urine and menstrual blood. The pelvic examination is done usually with the woman in the lithotomy position, with a pillow under her head. If she wishes, she may be placed in a semi-sitting position and offered a hand mirror so she can observe the external genitalia in the examination and learn more about her body. She is draped, so only the parts being examined are exposed. Women who cannot tolerate a lithotomy position, such as a frail elderly woman, may benefit from a sideline pelvic examination. The pelvic examination also can be done with the woman in a semi-Fowler's position, with her knees bent and feet on the examination table, rather than using the stirrups and having her hips at the edge of the table. The paraplegic woman, with no control over her lower extremities, usually can be examined with her legs separated in a V shape without her knees being bent. Necessary equipment to be assembled before the examination begins includes gloves, speculum, several sizes, including pediatric, should be available, slides, cotton swabs, a fixative agent, and a cytobrush and spatula for obtaining material for the cytology specimen, or pap test. A stool specimen may be obtained by the examiner during the rectal examination, and a slide for this specimen should be available. Equipment for specimens to identify vaginal infections should be available. External organs. The pelvic examination is conducted systematically and gently. The external organs are inspected for the degree of development or atrophy of the labia, the distribution of hair, and the character of the hymen. Any cysts, tumors, or inflammation of Bartholin's glands is noted. The urinary meatus and Skene's glands are inspected for discharge. Perineal scarring resulting from childbirth is noted. Speculum examination. A bivalve speculum of the appropriate size is used to inspect the vagina and cervix. The specula is warmed with tap water and gently inserted into the vagina. Plastic speculums do not get as cold as metal ones. Lubrication other than water or water-based lubricant on the cervix interferes with accurate cytology results. The size, shape, and color of the cervix are noted. Samples are taken for the pap test. Routine testing for gonorrhea and chlamydia is common because of the increased incidence of these two STDs. Additional samples of any unusual discharge are obtained for microscopic examination or culture. Bimanual examination. The bimanual examination provides information about the uterus, fallopian tubes, and ovaries. The labia are separated, and the gloved, lubricated index finger and middle finger of one hand are inserted into the vaginal introitus. The cervix is palpated for consistency, size, and tenderness to motion. The uterus is evaluated by placing the other hand on the abdomen, with the fingers pressing gently just above the symphysis pubis so that the uterus can be felt between the examining fingers of both hands. The size, configuration, consistency, and mobility of the uterus are evaluated. Feeling the fallopian tubes is usually impossible, although the ovaries may be palpated between the fingers of both hands. Because ovaries atrophy after menopause, palpating the ovaries of a postmenopausal woman may not be possible. Cervical cytology or Papaniculao test. Purpose. It is known that, in virtually all cases, changes occur in cells of the cervix before cervical cancer develops. These changes have been variously called cervical intraepithelial neoplasia, dysplasia, squamous intraepithelial lesions, SILs, and carcinoma in situ. Cervical cytology, or the Pap test, often combined with the test for HPV, is the most useful procedure for detecting precancerous and cancerous cells that may be shed by the cervix. As Pap testing became routine in this country during the past half-century, pre-invasive lesions, precancers, of the cervix became far more common than invasive cancer. Current guidelines. According to the most recent guidelines from the ACS, cervical cancer testing should start at age 21. Women under age 21 should not be tested. Women between the ages of 21 and 29 are recommended to be tested every 3 years. HPV testing should not be used in this age group unless it is needed after an abnormal Pap test result. Women between the ages of 30 and 65 should have a Pap test plus an HPV test called co-testing done every 5 years. Women over age 65 who have had regular cervical cancer testing in the past 10 years with normal results should not be tested for cervical cancer. Once testing is stopped, it should not be started again. Women with a history of a cervical precancer should continue to be tested for at least 20 years after that diagnosis, even if testing goes past age 65. A woman who has had her uterus and cervix removed for reasons not related to cervical cancer and who has no history of cervical cancer or precancer should not be tested. All women who have been vaccinated against HPV should still follow the screening recommendations for their age groups. Some women may need different screening schedules based on medical issues. Examples might include HIV infection, organ transplant, and exposure to diethylstilbestrol, DES. Procedure. With the speculum blades open and the cervix in view, samples of the superficial layers of the cervix and endocervix are obtained. Samples are best obtained with a spatula and a cytobrush, or with a broom-type sampling device. Specimens obtained with a broom-type device, such as those in the liquid-based ThinPrep or AutoCyte tests for cervical cancer, are stirred into the liquid that preserves the cells for analysis. The liquid-based tests use image processing to select the slides that need additional preparation by a technician for best analysis. We're going to skip classification of cervical cytology per our instructor. Rectal examination. The anus is inspected for hemorrhoids, inflammation, and lesions. The examiner's lubricated index finger is gently inserted and sphincter tone is noted. A slide may be prepared to test for the presence of occult blood in stool. High-sensitivity fecal occult blood testing is a useful yearly screening measure for colorectal cancer beginning at age 50. Only high-sensitivity forms of guaiac-based tests should be used for this purpose. A newer test, the fecal immunochemical test, FIT, may be done, requiring only 2 samples and having a high-quality stool-based screening and a lower risk for false positive results. Special instructions are necessary to prevent false test results when the woman is given materials for a FOBT. She should be instructed to do the following. Avoid aspirin and non-steroidal anti-inflammatory drugs such as ibuprofen or naproxen for at least 7 days before collecting the specimen. Avoid red meat, raw fruits and vegetables, horseradish, and vitamin C for 72 hours before testing. Collect a specimen from 3 consecutive stools. Return slides as directed within 4 to 6 days after the specimens are collected. Women's health problems. Cardiovascular disease. Cardiovascular diseases, CVDs, include disorders of the heart and blood vessels, such as myocardial infarction, MI, congenital abnormalities, and stroke. Those discussed here primarily relate to diseases of the blood vessels, particularly CAD. The topic is extensive, and only an overview will be presented in this text. A medical surgical text should be consulted for more extensive information about CVD and associated nursing care. CVD is the leading global cause of death, accounting for more than 17.3 million deaths per year, a number that is expected to grow to more than 23.6 million by 2030. Annual direct and indirect costs of CVDs and stroke total more than 316.6 billion. CVD is the number one killer of women, taking more lives than all forms of cancer combined and accounting for killing 289,758 women in 2013. Nearly half of all African American adults have some form of CVD, 48% of women and 46% of men. Sometimes CVD may be silent and progress undiagnosed until a woman experiences signs or symptoms of a heart attack, heart failure, an arrhythmia, or stroke. Whereas some women have no symptoms, others often experience symptoms of CVD that are typical of men: unusual fatigue, upper back pain, nausea and or vomiting, loss of appetite, dizziness, palpitations, jaw pain, and neck pain. These may occur during rest, begin during physical activity, or be triggered by stress. Stroke can be ischemic if a cerebral artery is blocked, or hemorrhagic if a cerebral artery ruptures. Almost 90% of strokes are ischemic. Women in the 45 to 74 year age group have a lower mortality rate than men in this age group. However, women older than 85 years have a higher stroke mortality rate than men in their age group. Metabolic syndrome, abdominal obesity, dyslipidemia, hypertension, hyperglycemia, doubles the stroke risk in women, but does not affect the stroke risk in men. Migraine, particularly with an aura, is associated with risk for stroke in women younger than 45 and has been associated with increased CVD risk. Symptoms of ischemic stroke appear to have few gender differences. Traditional symptoms include arm and or leg weakness and speech disturbance. Less common symptoms include facial weakness, loss of sensation in arm and or leg, headache, and non-orthostatic dizziness. Nurses should maintain awareness to identify possible risk factors in the women they encounter in care so appropriate teaching and referrals can be made if needed. The nurse should also share knowledge about risk factors and symptoms of CVD with the healthcare provider so referrals to specialists or appropriate laboratory tests are done. An environment of collaborative and participatory care may help women adopt health-promoting behaviors and receive specialized care when needed, and may help women achieve better health with weight control and exercise. Risk factors. Many factors increase risk for CVD, but common ones include hypertension, inadequate physical activity, overweight and obesity, and poor nutrition. These and other risk factors often contribute to development of other problems that further increase the risk for CVD, such as type 2 diabetes. Each risk factor may add to the risk for developing another of the problems listed here. Risk factors may be fixed or may be factors that can or cannot be changed. Aging is a major risk factor because the woman loses the protection that estrogen, secreted before menopause, exerts on the blood vessels. Estrogen's protective effect delays onset of CVD, making most women older at the onset of the disease than men. Other risk factors are listed in box 27.2 and are similar to those for men. Several risk factors deserve additional discussion in this chapter. The leading preventable cause of CAD and other diseases in women and men is smoking. Cigarette smoking adds to the burden of heart, blood vessel, and respiratory disorders, cancers, and many other diseases in women. Smoking is often more attractive to a woman if her family and friends smoke. She thinks smoking helps control her weight, or she thinks smoking reduces her anxiety. Both systolic and diastolic blood pressure elevations are associated with CAD and other vascular disorders. Adequate control of hypertension reduces death and disability from MI, stroke, and other blood vessel disorders. The person may not consider hypertension a problem because no symptoms are present. Smoking, overweight, and diabetes further contribute to hypertension. Hypertension is more prevalent in African Americans than in whites. Inadequate exercise contributes to many of the risk factors listed. Overweight and obesity are more likely when a person is sedentary, and these weight problems increase the likelihood that diabetes and hypertension will occur. Dyslipidemia, abnormal fat and cholesterol levels, is more likely in both women and men who do not get adequate exercise, adding further to the risk. Prevention is the key to reducing death and illness from all CVDs among women. Although once thought to reduce a woman's risk for CVD, estrogen's benefits for this have not proved true when hormone replacement therapy is chosen after natural estrogen levels decline at menopause. Health promotion activities to reduce the risk for coronary artery disease. Risk for CAD can be lowered with the following health promotion activities. Stop smoking. Maintain normal weight. Eat right. Limit alcohol to 1 drink per day if you're a woman. Control high blood pressure. Exercise. Control diabetes. To learn more about CVD and its prevention, visit these websites. Hypertension. People may be unaware of current definitions for the levels of blood pressure and do not seek the information because hypertension can be a disease that causes subtle damage over long periods. Current standards that define hypertension are lower than what many people expect. Normal, less than 120 millimeters of mercury systolic, less than 80 millimeters of mercury diastolic. Pre-hypertension, 120 to 139 systolic, 80 to 89 diastolic. Hypertension, 140 or greater systolic, 90 or greater diastolic. Lowering hypertension, including isolated systolic hypertension in older women, to levels less than 140 systolic and less than 90 diastolic, reduces the risk for CAD and stroke. Even borderline or prehypertension can be dangerous. Medication should be considered if regular aerobic exercise, weight reduction, improved nutrition, and stress management do not lower blood pressure adequately. The dietary approaches to stop hypertension diet plan from the National Heart, Lung, and Blood Institute of the National Institutes of Health is often recommended to maintain good blood pressure control and can be retrieved online. Diet and glucose control. Women with diabetes have relatively greater risk for CAD than men, so maintaining weight and glucose levels within normal limits is especially important. Diet is a primary means to control the lipid profile. Diet recommendations should be individualized, but general guidelines are that fat intake should be a maximum of 30% of daily calories, and no more than 10% of daily calories should come from saturated fat, found in foods such as meat, butter, cream, and cheese. Cholesterol intake maintained lower than 200 milligrams per day is ideal. Increased evidence shows that fish, especially fatty fish, confers cardiovascular benefits, and at least 2 servings per week is recommended. Eating a diet high in vegetables, fruits, and low-fat dairy products and limiting salt intake to under 6 grams per day and alcohol to a maximum of 1 drink per day have shown to be beneficial at reducing blood pressure in women. Increased activity. Aerobic exercise helps control weight, blood pressure, lipid profile, and glucose level. It reduces body fat while increasing muscle mass and improving muscle tone, making it easier to maintain a healthy body weight or reduce weight if overweight or obese. Additionally, it reduces stress and depression. As described by the Physical Activity Guidelines for Americans, adults should engage in at least 150 minutes of moderate intensity activity each week. Aspirin. Low-dose aspirin therapy, 81 milligram or a baby aspirin, is well accepted as an agent for the secondary prevention of cardiovascular events, and current guidelines also define a role for aspirin in primary prevention. Low-dose aspirin therapy each day has been shown to be beneficial to inhibit platelet aggregation, which can increase clot formation and lead to CAD. Acute chest pain should be treated with a single adult dose tablet, 325 milligrams equivalent to 4 baby aspirin tablets, as soon as MI is suspected to reduce clot formation and increase the chances of full recovery. Aspirin use in males is primarily intended for the prevention of CAD, whereas in females, stroke prevention is the focus area. For those unable to tolerate aspirin or who have recent GI bleeding, prescription drugs such as Plavix may be prescribed. Individual needs are based on age, risk factors, and history. Disorders of the breast. Benign disorders of the breast. 4 relatively common benign disorders of the breast tend to occur at different ages. Fibrocystic breast changes. Fibrocystic breast changes are common breast changes during the reproductive years before menopause, or permanent cessation of menstruation. Fibrosis, or thickening of the normal breast tissue, occurs in the early stages. Cysts may form in the latter stages and are felt as multiple, smooth, well-delineated nodules that have a tender, movable character. The lumpy, rubbery, or rope-like nodules often vary in size, from less than 1 centimeter to several centimeters. Fibrocystic changes are not cancerous, although atypical hyperplasia of the terminal breast ducts or lobules is associated with a greater risk for breast cancer. Tissue specimens obtained by fine needle aspiration or from an open surgical biopsy are examined to identify the tissue type and any malignant changes. The most common symptom of fibrocystic breast changes is pain and tenderness. The pain is often bilateral and most noticeable during the premenstrual phase of the normal cycle. Women with large breasts may have pain associated with stretching of the breast ligaments. Premenstrual pain is believed to be the result of an imbalanced estrogen to progesterone ratio. Women with fibrocystic breast changes improve dramatically during pregnancy and lactation because the large amounts of progesterone present during pregnancy block the excess amounts of estrogens present when the woman is not pregnant. The initial therapy varies with the age of the woman and her risk for breast cancer. Aspiration of cysts may relieve pain, with follow-up needed only if the cyst recurs or fluid aspirated is suspicious. The bilateral nature of the changes in pain suggests that the condition is benign, but definitive studies, such as mammogram, study of breast tissue with low-dose radiography, and ultrasound imaging, FNA of the cysts, or surgical biopsy may be needed to identify malignancy. Fibrocystic breast changes may fall into the following 3 categories: non-proliferative lesions, hyperplasia without atypical cells, atypical hyperplasia. Hyperplastic lesions with atypical cellular changes have an increased risk to become malignant, but most women with fibrocystic breast changes do not have a greater risk for breast cancer. Specific symptom relief for fibrocystic disease has not proved beneficial, but some methods may be worth trying. Wearing a support bra is a simple way to reduce pain from large breasts that stretch ligaments. Avoiding caffeine and other stimulants, coffee, tea, chocolate, and some soft drinks, reduces levels of methylxanthines, which may increase discomfort during the last half of the menstrual cycle. Oral contraceptives taken during the secretory phase, second half, of the menstrual cycle have been successful, but pain returns if the contraceptives are discontinued. Danazol, Danacrine, an androgenic medication that suppresses estrogen production, may be given for severe pain, but for no longer than 4 to 6 months. Other possible drugs include bromocriptine, a prolactin inhibitor, and tamoxifen, an estrogen inhibitor that is usually given in breast cancer treatment. Fibroadenoma. Fibroadenomas are common benign tumors of the breast, and although they may occur at any age, they are most common during the teenage years and the 20s. Fibroadenomas are composed of both fibers and glandular tissue. They are firm, freely mobile nodules that may or may not be tender when palpated. Fibroadenomas do not change during the menstrual cycle. They are generally located in the upper outer quadrant of the breast, and more than one is often present. Treatment may involve careful observation for a few months to determine whether the mass is stable. FNA or a core biopsy of the tumor is done if the mass continues to enlarge. The mass may be excised and the specimen analyzed to rule out malignancy if results of other diagnostic tests are not conclusive. Ductal Ectasia. Ductal ectasia usually occurs as a woman approaches menopause. It is characterized by dilation of the collecting ducts, which become distended and filled with cellular debris. This initiates an inflammatory process resulting in the following: a mass near the areola that feels firm and irregular, enlarged axillary nodes, nipple retraction and discharge. These signs and symptoms are similar to those of breast cancer. An accurate diagnosis through biopsy is vital. Although ductal ectasia is benign, the ducts may be excised to prevent further discharge or remove an abscess that results from infection. Intraductal papilloma. Intraductal papilloma develops most often just before or during menopause. It occurs when papillomas, small elevations or protuberances, develop in the epithelium of the ducts of the breasts, often under the areola. As the papilloma grows, it causes trauma and erosion within the ducts that results in serous or bloody discharge from the nipple. Ultrasonography and diagnostic mammography aid in the diagnosis of the intraductal papilloma. Treatment consists of excision of the mass and ductal area, plus analysis of nipple discharge to rule out a malignant tumor. Long-term follow-up is essential to identify any malignancy early. Nursing considerations. The nurse should acknowledge the anxiety that all women feel when a breast disorder is discovered. Furthermore, the apprehension continues for most women while they await a final diagnosis. Some women may find it helpful to learn that most breast disorders are benign. Some benign disorders do increase the risk for later occurrence of cancer, however. For others, the most helpful intervention is to encourage them to express their concerns. Diagnostic procedures. Differentiating between benign and malignant breast disorders may require diagnostic procedures. Ultrasound examination can be used to discriminate fluid-filled cysts from solid tissue, which is more likely to be malignant. Fine needle aspiration biopsy can be done to remove fluid or small tissue fragments for analysis of the cells. Core biopsy uses a larger needle to obtain a cylinder of tissue from an area of questionable breast tissue. Open or surgical biopsy is performed to remove all or part of the lump of breast tissue if the following other conditions exist. Suspicious mass that persists through a menstrual cycle, bloody fluid aspirated from a cyst, failure of the mass to disappear completely after fluid aspiration, recurrence of the cyst after 1 or 2 aspirations, solid dominant mass not diagnosed as fibroadenoma, serous or serosanguinous nipple discharge, nipple ulceration or persistent crusting, skin edema and erythema suspicious for inflammatory breast carcinoma. Suspicious mammography or ultrasound findings. Known or possible genetic abnormality that increases a woman's risk for breast cancer. Malignant tumors of the breast. Incidence. The lifetime risk for a woman to develop breast cancer in the United States is 1 in 8. In 2016, an estimated 246,660 new cases of invasive breast cancer are expected to be diagnosed in women in the United States, along with 61,000 new cases of non-invasive in situ breast cancer. Deaths in women are expected to be approximately 40,500. Breast cancer in men is rare, with an expected 2,600 new cases in men and 440 expected to result in death in 2016. The lifetime risk in men is estimated to be 1 in 1,000. Breast cancer is a major type of cancer among women of all races. Breast cancer incidence rates are highest in non-Hispanic white women, followed by African American women, and are lowest among Asian Pacific Islander women. In contrast, breast cancer death rates are highest for African American women, followed by non-Hispanic white women. Breast cancer death rates are lowest for Asian Pacific Islander women. Breast cancer incidence and death rates also vary by state. Risk factors. Although the actual cause of breast cancer remains unknown, several risk factors are known to increase the risk for development of breast and ovarian cancer or other diseases. Mutations in 2 genes, BRCA1 and BRCA2, thought to be responsible for most cases of familial breast and ovarian cancer, including breast cancer in men, continue to be studied. Mutation of the CHEK2 gene has shown higher risk for development of breast cancer in both men and women. Mutation of the p53 tumor suppressor gene has been associated with breast and other cancers. Study of genetic links to many types of cancers and non-malignant diseases is ongoing. Because research has linked these and other genes to an increased risk for breast or other cancers, testing is offered to the woman having a higher risk or who has developed cancer at a younger age than expected. Knowing risk factors is important to guide breast cancer screening and treatment processes so cancer is diagnosed at the earliest stage possible. It is also important for the nurse to convey to women that many breast cancers develop in women with no known risk factors, whereas other women with one or more risk factors do not develop breast cancer. Pathophysiology. Approximately 65 to 80% of breast cancers are infiltrating ductal carcinoma, which originates in the epithelial lining of the mammary ducts. The cancer becomes invasive when it is no longer confined to the duct and spreads to surrounding breast tissue. Another 10 to 14% of invasive breast cancers are infiltrating lobular cancer that originates in the milk-secreting pockets of breast tissue. Most breast cancers grow in irregular patterns and invade the lymphatic channels, eventually causing lymphatic edema and the dimpling of the skin that resembles an orange peel, peau d'orange. Several types of breast tumors may be present at the same time. Inflammatory breast carcinoma, IBC, has cutaneous findings with invasive involvement in the dermis. IBC is rare, occurring in 1 to 2% of U.S. women and more likely to occur in younger or African American women. IBC is aggressive and may manifest as a pink or red skin rash rather than a distinct lump that might show on imaging. Tenderness, itching, or breast edema may be present. These characteristics are typical of infection, so antibiotics are often prescribed. A woman should promptly contact her healthcare professional for follow-up testing if antibiotics do not quickly clear the infection. Then the true cause for the woman's signs and symptoms can be determined, and cancer treatment can be started if needed. Cancer cells are carried by the lymph channels to the lymph nodes, and 40 to 50% of patients have involvement of axillary lymph nodes at the time of diagnosis. By the time a patient consults a physician, breast cancer already may be a systemic disease rather than being confined to the local tissue. Metastasis occurs when the malignant cells are spread by both blood and lymph systems to distant organs. Distant metastases include the lungs, liver, bones, and brain. Staging. Confirmation of malignancy is the first step in evaluating the woman with cancer, and staging is necessary to understand the severity of the cancer and plan the best therapy. Staging is based on the tumor, node, and metastasis (TNM) system used to describe the cancer's anatomic extent. Stages of breast cancer progress from stage 1, indicating a small tumor without lymphatic involvement in the local area of metastases, to stage 4, which indicates spread to lymph nodes and metastases to distant organs. The stages are used to guide treatment and help provide a prognosis. The type of cancer cell, the presence of hormone receptors, and the proliferative rate of the breast cancer cells are also important factors in the rate of recurrence and determination of the most appropriate treatment. Management. Many new treatments have emerged. A combination of surgical excision of the tumor and locally involved lymph nodes and adjuvant therapy, added treatment to enhance action, is recommended. The combination of therapies is individualized for each patient. New techniques, medications, and management emerge frequently, and the nurse who cares for women with cancer should stay informed about changes in therapy. Surgical treatment. The surgical procedure depends on the type, stage, and location of the disease. The most common surgeries are the following. Breast conservation treatment, which involves wide local excision, lumpectomy, of the tumor to microscopically clean margins for tumors that are small relative to the breast size. The excision can be performed without major cosmetic deformity. Varying numbers of axillary lymph nodes are usually removed to identify the stage of the woman's breast cancer. Quadrenectomy is a more extensive surgery for a breast tumor, removing a quadrant of tissue. Removal of the tumor involves resection of the skin and other tissue in the area to reach a microscopically clear margin of healthy tissue. Analysis of lymph nodes removed during the quadrenectomy allows staging of the cancer. Simple mastectomy, which is removal of the entire breast. Axillary dissection is omitted, although some lymph nodes may be removed for staging purposes. It may be recommended for selected cases in which prophylactic removal of the breast is considered for a woman at high risk for development of breast cancer, Simple mastectomy in the absence of cancer does not eradicate the risk for later breast cancer, however, because a small amount of breast tissue remains. Modified radical mastectomy, which involves removal of breast tissue, axillary nodes, and some chest muscles. However, the pectoralis major muscle is preserved. This surgical procedure may be recommended when a single large primary lesion or multiple lesions exist in a relatively small breast because cosmetic results may be less than satisfactory with the other methods described. Other factors include whether the woman can undergo radiation therapy. Radiation therapy after surgery may not be possible if she is pregnant, has had prior breast or chest radiation, or has an autoimmune disease such as systemic lupus erythematosus. Sentinel lymph node (SLN) biopsy is a technique to remove a few key lymph nodes to evaluate cancer spread rather than removing most of the nodes in the area, axillary dissection. A radioisotope suspension or a special dye is injected near the tumor site, where it is transported by the lymphatics toward the axillary nodes and trapped by the first one or two lymph nodes, or the sentinel nodes. The nodes identified by one or both of these techniques are excised for evaluation. If cancer has not spread to a sentinel node, the surgeon does not need to remove a large number of lymph nodes for staging of the cancer. Reducing the number of lymph nodes removed helps avoid some of the problems caused by lymphedema. Adjuvant therapy. Adjuvant therapy is supportive or additional therapy that is usually recommended after the surgical procedure. Radiation, chemotherapy, hormone therapy, and immunotherapy are adjuvant therapies that are often recommended. The decision about adjuvant therapy is based on the woman's age, the stage of the disease, the woman's preference, and the hormone receptor status of the lesion. Radiation and chemotherapy are known to improve the chance of long-term survival, and one or both are usually recommended after surgical excision of the tumor. Research continues to determine the best use of these adjuvant therapies when treating breast cancer. Radiation therapy. Radiation uses high-energy rays to destroy cancer cells that remain in the breast, the chest wall, and the underarm area after surgery. The lymph nodes above the clavicle and the internal mammary lymph nodes are also irradiated. Radiation may be used to reduce the size of a large tumor before surgery. A radiation oncologist directs use of radiation in cancer therapy. The skin in the treated area may have a reaction similar to sunburn. Lymphedema is more likely to occur if the axillary lymph nodes are treated. A newer technology to limit the adverse effects of radiation on normal tissues while giving a maximum dose of radiation to the tumor site is intensity modulated radiation therapy. Chemotherapy. Chemotherapy drugs are designed to kill the proliferating cancer cells. The specific combination of drugs and the number of treatment cycles are individualized for factors such as type of cancer cells, the woman's age, the hormone receptor status of malignant cells, whether she is postmenopausal, and other important factors such as medication she needs for non-malignant disorders. Chemotherapy may both precede and follow tumor removal. Depending on the specific drugs, chemotherapeutics often kill normal cells, usually rapidly dividing cells such as those in the mucosa, the blood cells, and the platelets. For this reason, the woman often has sore bleeding gums or other bleeding tendencies and may be more susceptible to infection during treatment. Loss of head and body hair or menstrual irregularities are common side effects during treatment. Anemia with resulting fatigue is common because erythrocyte production is impaired. Antiemetic drugs control nausea for most women. Hormone therapy. Medications to reduce production of estrogen are prescribed because many breast tumors are estrogen and/or progesterone receptor positive, meaning that their growth is stimulated by estrogen. Estrogen receptor positive tumors may occur in both premenopausal and postmenopausal women. Risks and benefits of proposed estrogen blocking medications are discussed with the oncologist, particularly in premenopausal women, because their estrogen and progesterone levels are coordinated with their menstrual cycles. Tamoxifen is one of the oldest estrogen-blocking drugs given for breast cancer to prevent recurrence. However, tumors in some women become resistant to tamoxifen, and the cells actually use the drug to stimulate growth. Laboratory values for calcium, cholesterol, and triglycerides may be elevated with tamoxifen. Anastrozole, Arimidex, Exemestane, Aromacin, and letrozole, Femora, are aromatase inhibitors that hinder production of estrogen because they block conversion of androgens to estrogen in postmenopausal women. Aromatase inhibitors are being studied as alternatives to tamoxifen because they inhibit estrogen in a different way. Tamoxifen, Avista, is an estrogen modifier used to reduce osteoporosis by binding to estrogen receptors. Therefore, this drug also blocks estrogen effects on the breast. Raloxifene lowers levels of low-density lipoproteins and cholesterol. Immunotherapy. Trastuzumab Herceptin is a biologically based therapy that targets cell pathways that promote cancer growth. Some tumors produce excessive amounts of the HER2 protein, promoting tumor cell growth. Trastuzumab blocks the effect of this protein to inhibit growth of the cancer cells. Research is ongoing into other immunotherapy for breast and other cancers. Breast reconstruction. Timing. Breast reconstruction is often an option in breast cancer treatment. The timing of reconstruction should be discussed with the woman before surgical treatment. Immediate reconstruction has a psychological appeal, but expected therapy after surgery may have aspects that make later reconstruction the best option. The prospect of having life-threatening breast cancer and simultaneously facing the loss of a breast may be overwhelming for many women. Conversely, delayed reconstruction may give a woman time to learn about the procedure, to heal from the mastectomy, to consider her values and desires for added surgery. Methods. Several methods of breast reconstruction are available. The tissue expansion method uses an empty silicone prosthesis fitted with a valve that can be accessed by percutaneous needle puncture. The bag is filled with saline in small increments to slowly expand the tissue. When the desired volume is attained, the incision is reopened, the device is removed, and the expander is exchanged for the appropriate implant. In some models, only the valve must be removed and the expander serves as the permanent implant. Tissue flap procedures move autogenous tissue from the back, abdomen, or buttocks to create a breast mound. Although these procedures do not always involve implants of a foreign substance, as the tissue expansion method does, they involve at least 2 incisions, one at the breast and one at the site of the woman's donor tissue. Not all women are suitable for muscle flap grafts, particularly those with diabetes or connective tissue disorders and those who smoke, because these procedures involve altering the blood supply to the transplanted tissue with the possibility of poor wound healing for these women. Thin women may not have sufficient tissue for transplant to the breast. Psychosocial consequences of breast cancer. The time from discovery to treatment of breast cancer is the most stressful time for many women. Factors that contribute to pre-surgical distress include a sense of uncertainty, incomplete information, the need to make difficult treatment decisions, and scheduling problems. Surgery may be preceded by chemotherapy and adjuvant therapy, or these therapies also may follow surgery. Because of the many complexities to be considered for treatment to be most effective, consultations with several specialists, including a surgeon, a radiation oncologist, a plastic surgeon, and a medical oncologist, are needed. Scheduling difficulties arise when women must travel significant distances for treatment. The many appointments with unfamiliar specialists and studies to determine best treatment often result in frustration and confusion for a woman and her family. Concerns frequently expressed during treatment for breast cancer include fear of death, uncertainty about the quality of life, changes in body image, the effect on sexuality, and side effects of recommended therapy. For most women, the knowledge that they will lose their hair as a result of chemotherapy creates one of the most difficult situations in therapy, adding yet another assault on their body image. Breast cancer has psychological consequences not only for women, but also for their significant others. Women who are diagnosed in their 30s may have young children who cannot understand why their parents are so worried. Difficulties reported include sleep disturbances, eating disorders, and problems with work responsibilities. The marital relationship may be strained, primarily in the areas of sexual relations and communication about matters related to the illness. Women and their partners sometimes differ in regard to how much they want to discuss the illness. Some women have a great need to discuss their diagnosis, treatment, and fears of recurrence. Other women and many men view discussion of such fears as negative thinking that delays adjustment.